Good evening, welcome. I'm Vice Principal Professor Jeff Hayward. It's my pleasure to host Andrew Thompson's inaugural lecture this evening, taking up his personal chair in public policy and citizenship. Andrew says that he was born in the army quarters in the Pentland Hills, no doubt to the sound of the firing ranges at Redford, to which many of us wake up. And had a nomadic early life, no doubt following the career, the military career. He took his first degree at UMIST, University of Manchester Institute of Science and Technology, and then graduated there from a PhD, and followed a career of research and academic life, working for the public sector in local authority and in university, until he came to the University of Edinburgh in 1997 as senior lecturer in quantitative methods. He was promoted to personal chair of public policy and citizenship in 2011. Andrew says that his work has been based fundamentally around an empirical, fundamental and applied interest in user and citizen-focused change, and in the quality of service and improvement of public services. And I think that his lecture, and the title of his lecture, The State of the Citizenry, Views from the Communities, is clearly going to cover those topics. Three main strands of interest throughout his academic career: the citizen experience and the involvement of citizens in their services, an interest in that arch bureaucracy, the European Commission, as a public administration, and those of us who have dealt with with the European Commission actually may want to pick his brains about how it really works. And then widening participation in higher education, which is an interest that he's kept from his student union days in Manchester. He also says that apart from time with his family, he tries to control a garden that is too big to manage effectively, which I guess demonstrates that the power of numbers is actually not all powerful, and that there are some things that even numbers cannot manage to achieve. So, I'd like to welcome Andrew to give his inaugural lecture to us, The State of the Citizenry, Views from the Communities. Andrew.
Thank you. Well, thanks very much, Jeff, for that kind introduction, and a big welcome to you. Even though we're small in number, as my brother said, it's about quality, not quantity. So, although I'm a quantitative methods person, I actually have mixed methods within my research skills. First of all, I just want to say thank you. And it's thank you to a lot of people. I'm not going to list them all because that would take up most of the time. But clearly, there are a number of people who have been very important to me in this journey of work and life. And I want to say thank you to my family, Leslie, Innes and Isla, who are sitting here, who've coped with my erratic ways of working and temperament through a number of periods of crisis of trying to get work finished within deadlines, and supported me throughout. So I thank them very much. And my extended family, my brother and my brother-in-law and sister-in-law as well, and friends, and some friends are here. Maddie Halliday, who has been a lifelong friend, working on similar kind of issues outside the university. But also a whole range of colleagues, professional colleagues and support colleagues who've been extremely important in keeping me on the right tracks, challenging my ideas, but being great to support me in trying to understand and cope with the work which we obviously face as academics. But also I want to extend a big thanks to the students. Unfortunately, none of my PhD students can be here, but are past or present. But they have also been very important in challenging my ideas, making me think much more widely and deeply about a lot of subjects, and taken me to another level. So it's not a journey just for me, but for me in conjunction with a lot of people. And obviously the personal is very important as well as the professional. So what I'm going to try and do, I suppose everyone tries to do, is to make sense of a lifetime of research, and teaching and other things that we do as academics against this background of the life course. And I have to say, and maybe many people say it, but it's clearly not a coherent life course or work pattern. I do think there are some people who manage that, and I don't know how they do it. It's certainly been a very diverse set of activities that I've been involved in, and sometimes seemingly very disjointed and very fragmented. But I think that just reflects life. But I think the nice word, the kind word to use about myself may be eclectic, but it certainly involved many different disciplines and environments. And I'm going to just tell you a little bit about some of that. Jeff has already alluded to this. There are these three main areas. Citizen experience and involvement in health services, which has been, I suppose, my passion throughout my adult life. There is this aspect of widening participation in higher education, which is linked, as you can imagine, to citizenship. And there's also this newer area of research which I've got involved in, trying to understand the European Commission from the inside. It's one of the biggest administrations, most powerful administrations in the world, and yet we know very little about it. I'm going to focus, the other thing, key thing for me has been the interest in methodology. To me, knowledge is entirely dependent on the methods we use to create it. And I give a lot of emphasis to that. And it might be in terms of the data creation methods, because I don't believe we collect data. I think it's always created. In terms of the analysis, which might be a mixture of qualitative and quantitative analysis, and my passion for using mixed methods, which has increasingly been of interest to me in trying to theorize how this contributes to knowledge creation. But I'm going to focus entirely this evening on this main area to do with citizen experience and involvement in health services, and hopefully make some sense of it for you. There have been quite a few research projects. I'm not going to read them all out, just there have been quite a few which have been linked to this theme, which I've been involved in. You'll notice that some of them are focused within areas of Spain, where I have a lifelong interest and continuing interest, a very productive relationship with them, as well as in the UK. And the UK, increasingly more fragmented, more diverse, devolved administrations and so on, with this natural experiment going on, which is increasingly of interest to me. But also looking at it in terms of European strategies and the increasing concern with cross-border movements and quality strategies and how they impact on patients in different European hospitals. And maybe we'll look at primary care later on as well. I'm going to start with trying to understand, explain what I understand by community. It's a word which is used and misused an awful lot, and it's not always clear what people are talking about. And I'm going to look at it in 4 different ways. So one is the location. Often people mean a geographical location, which you'll notice there I list it as being at very different levels. Also, we can think of it in terms of sociodemography, the ascribed characteristics of gender, age, ethnicity, and also issues to do with social class and economic status. Increasing interest in identity, although I have to say it's not been the main focus of my work. And here we can think of examples of identity being identified through disability, sexual orientation, Scottishness, number of different characteristics. And the more interest for me is the interest groups themselves, which are often based on community actions, voluntary organisations working at the local level, but sometimes at the national level, the regional level, and often identified in health services with particular conditions. So it may be a cancer support group, for example, or people working with dementia. Putting it in a political context, what I'm interested in is how citizens operate and think about these different levels of the polity, as we call it, different levels of governance which have emerged and are increasingly important. So we can think of this politically as voters, either with local authorities, maybe, this is a Scottish example, and then to Scottish Parliament, the UK Parliament and the European Parliament, and also, on the other side, thinking about health service links, health boards within Scotland, NHS Scotland, the Department of Health, which might be within England, within Scotland, or the regional administrations, and also at the European level. You might say, well, there is no remit for healthcare at the European level. No, but there is interest which is increasing, given cross-boundary flow of people expecting quality services wherever they go across Europe, and the European Commission is increasingly funding research to look at these issues, especially alongside some of the developments in the European Court of Justice, setting rights for patients to move to expect certain services. So there is a European context to this as well. I'm going to bring in the Scottish Health Council here because they, although they don't represent patients or the public, they are there to make sure health boards are providing a patient focus and public involvement in their agendas. But people as citizens can operate through community councils or through a number of different termed boards, patient public panels, public partnership forums, and various groups within what are called managed clinical networks. And there'll be others as well. But these are examples of how it operates in Scotland. I want to just give some context to this because one of the concerns, as you may be aware, is what appears to be happening across the world, although this is a very limited set of examples, but a declining rate of participation in voting. People are voting less, and it's clearly become much more of an issue amongst younger people. There's a generational decline in voting for parliaments. We can also look at this within Europe, and you can see there very clearly how the participation rate, the turnout, has been going down since 1979 over that 30-year period, quite considerably from nearly 2/3 to well under half. And you'll also see how it varies by state. And some of the high turnouts, Luxembourg, Belgium, are because it's compulsory. That's not the case in most places. You see how low down the UK is, for example. So there is apparently a crisis of legitimacy for elected governments, trying to govern on the basis of minority votes. And so it raises questions for politics and for policy formation in terms of democratic practice. If representative government is declining, or declining interest amongst the citizenry, what are the alternatives? And the alternative that people turn to is to say, well, they can do and do get involved more directly. Direct participation, expression of voice within the system. And maybe we should give much more attention to that as being the way people now want to work politically. And what we're seeing then is a shift from government to what is known as governance. And some people say, isn't that just semantic difference? Well, I think it's actually trying to encapsulate this change from government, if you like, doing things in the state for the citizens, or to the citizens, to this idea of saying, well, actually, they don't have legitimacy and authority to do that. There's also much more complexity or recognition of complexity in the public sector and some of these wicked problems that are well known, such as poverty reduction and so on. And thinking about how can we bring citizens into this governing of society. Not just citizens, but businesses, voluntary sector, and so on. And one of the tensions, I think, between the devolved nations is this tension around what in Scotland would be called mutuality and in England would be called, well, marketisation. And within those collectives, if you like, those stakeholder groups, as Callaghan and Wistow say, there's an important issue here to understand that relationship between the roles of stakeholders and the different claims to knowledge and legitimacy within each of those, where, if you like, the power is contested. So we have to understand the different positions of the different stakeholders within this governance. And so it leads to consultation efforts with individual citizens through surveys, opinion polls, interviewing, with elites, with general population and so on. And some of you might feel inundated with these kind of surveys which are done. And increasing attention to what is called deliberative forms of democracy. Bringing people together to discuss as a group. It might be a focus group, although they tend to be very limited in terms of timescales, but also thinking about bigger groupings over time, maybe a citizens' jury approach or a panel or a series of workshops. I'm just going to mention this as a kind of context, is trying to think about what are the policy options for involving citizens then in the nation or in their society. And what Chris Hood and others have talked about is the shift from the representative, the political form through representation, to more regulation, away from collective approaches to more individualized approaches. And outside the political sphere, thinking of that in terms of co-production, and I'll come back to this theme a lot, or choice, if you like, the mutuality agenda versus the market agenda. So in terms of trying to involve citizens in the public services, what we're looking at is a move from what is often called the disempowered collectivist approach, the traditional way, the bog standard schools, health services and so on, so-called, where, if you like, the beneficiaries, the people who are supposed to get the benefits of the services, the citizens, have no voice, no choice, they're dependent, they're locked in, and there's no involvement. Now, that's obviously an idealized form. It's not true exactly like, but it's a kind of stereotype, if you like. And the question is where we move, or where people want to move. Do we move to a more powerful collective approach through what I would call a citizen agenda, giving voice, participation, political influence? Or do we move to an empowered but individualistic approach, a consumer position, giving the options for exit, making sure they have information to make decisions, and having control over the resources individually? Or is there a move towards what might be called a very disempowered market position of, I hate the words, but this is what is now talked about, responsibilized agents? In other words, you will make a choice. You have the choice to go there, or exit from the system, but actually the choices are pretty poor, if any. But you have to take responsibility for making the right decision. So I want to polarize these positions, and some people say, well, they're not necessarily opposites. But I think it's helpful to think in terms of them as being different positions. And just to give it some political philosophy, and I apologize to any philosophers who kind of say, well, it's a bit crude, your stereotyping here. But I think we can think in terms of the neoliberal position, which is largely about individualism, giving people the freedom to make choices, liberating them from the market, from the state, but that means in practice to the market, and we have to decide whether the market is liberating, and giving people power within public services, because public services presumably will continue in some form, but giving them the choice to exit when they're dissatisfied, or if they can't exit, be able to use voice for making complaints, essentially. So it's what I would call the consumer-customer position. The alternative philosophy is civic republicanism, and I'm going to allied it with communitarianism, although I know there's subtle differences between them, which is more about collective freedoms. In other words, individuals are only free due to collective approaches to ensure inclusiveness and to ensure some sort of equity and meeting diverse needs of society. This is what is often known as the social democratic conception of stakeholder society. And empowerment for citizens then isn't through exit, it's through voice, giving people the power to say what they think as co-producers. So I just want to kind of suggest there may be an importance in the label we use. And some people say, well, a label. What's a label? But I think it conveys certain things. And we know that the power of language isn't just to describe the position people are in, but often to try and position people in a way they hadn't really thought about themselves. So a user is the most neutral language, perhaps, somebody who receives services. A client is a user, but this is where a professional decides whether they can have access to services. So we often think of, say, social work clients, but it's the social work teams who will decide whether that person can be a client of theirs or not. Viv may come back to me on that, but it's the way I understand it. A consumer is not a producer, by definition. They have rights, but no responsibilities in service delivery. They simply consume. A responsibilized agent is a user who has little, if any, meaningful choice, but they have to choose and be responsible for it. A customer, I think, is a stage on from the consumer position. It's a consumer who, on the basis of ability to pay, has the right to choose a service and the provider and to receive the service they expected. So what is a citizen? And I'm not sure that everyone would agree with this definition, but I was trying to think, how would you define a citizen in this context? I would say it's an owner of state services, key stakeholder, clearly, as a voter, as a taxpayer, and as a member of these various communities that we're going to be looking at, with rights and responsibilities for the co-production of services. Okay, so it's not saying they don't have any responsibilities, but it's much more around co-production. I perhaps will skip over this rather quickly, but there is an important argument. Why are we looking at consumerism? Yes, there's a neoliberal agenda, but why has that come into place? And it's arguably around late modernity, and, if you like, active citizenship requires much more autonomy of individuals. I have a problem with the way people use autonomy, because to me, autonomy means independent action. And I think often it's not seen as that. So, for example, in health services, people talk about shared decision-making between professionals and patients, and say that's an autonomous position. To me, it's not. It is an interdependent position, and it's not the same as independence. But I think what Foucault was picking up here was this idea that we're moving from welfarism to neoliberalism, and this idea of there are new sites of struggle between people and states and the global economy. So it leads to a number of tensions. I think that's what I'm trying to identify here. First of all, is this issue about, is it about choice or is it about equity? Some people, like Julian Legrand, argue that you get both. Choice produces equity. I don't agree with that argument. There's also a tension around, is it about needs or is it about wants? They may be the same, but they may be very different. Is it about rights and resources? How do you reconcile those different tensions? There's also increasing contestation, if you like, between professional and lay power and knowledge. Who has the right to say? Which should have the greater weight in decisions that are made? And this tension around making people responsible to make choices, even if they don't want choices. So I think this is interesting. Andrew Gray's work on this as well has said there are these policy risks if you treat people as customers. One is that choice might aggravate the inequalities. Secondly, that people might get inappropriate services because they want something which isn't actually appropriate. Who decides? Well, that's the question. Or they may make unrealistic or improper demands, what in philosophy would be called the moral hazard. So I just wanted to look, first of all, very briefly, at choice. Some research I've done with colleagues in Stirling, Dundee, Glasgow and Oxford was trying to look at this concept of choice through a number of specific decisions that people were placed in. And rather than seeing choice as this menu of items, oh, I'll have that one, thank you, which is a kind of supermarket approach, trying to understand this as a process. So, first of all, recognizing, clarifying the problem, identifying possible solutions, appraising those solutions, selecting then a course of action, implementing it, and evaluating it. And I don't want to spend too much time on this, but just to say we looked at a number of different decisions. One was with antenatal care for women, the choice or decision to have a screening test for Down syndrome. So very specific, if you like, the micro detail of healthcare. And what we found there is that those who saw choice existing, to choose to have that test or not, had greater personal experience. But most people who didn't have that experience just saw it as routine and expected. It wasn't a choice, you just did it. That's what you did when you had a baby, one of the things you did. However, diagnostic or abnormality tests were usually seen as a choice. So it depends on what kind of test we're talking about. But most people did feel they had a choice. When we looked at people who had lymphoma, Hodgkin's or non-Hodgkin's lymphoma, we found that the treatments were very protocol-driven. In other words, evidence-based medicine has suggested this is the way you deal with lymphoma, and therefore the only alternative to most people seemed to be to refuse to have it, which really didn't feel like a choice. You have a treatment or you don't have a treatment. However, the more high-risk experimental treatments were more likely to be seen as choice. So one decision might be seen as a choice and others not. It's a bit unclear. And not all people wanted the choice. Many preferred the professional to make the decision, to trust the professional, often through discussion, but to let the professional make the decision. And the final case I want to show here is with carers, often partners, not always, who are looking after somebody who has dementia. How do you make the decision? What choice did you feel you had about making the decision about where this person would live? In your own home, in a relative's home, or in a residential nursing home? And we found that our group was much more educated, much more aware of choices, but there might be sudden changes. So the person might be sectioned, or the carer, him or herself, might be ill, and suddenly it felt like a loss of control, and therefore choice wasn't in their mind at all. A lot of these decisions they felt were routinized, and therefore weren't actually decisions they had to make. It's just something which happened. But clearly for people who are partners, whether your carer went into a home or not was not seen as a choice. They just said, no, you look after them. It's your partner. That's what you do. Until the point where you can no longer do it. And so for them, there was no choice in that. And there was this great concern about having power over the lives of others. So what I'm trying to suggest here is that choice can be a bit of a mirage. Sometimes we see it, sometimes we don't. It varies considerably by the kind of condition we're looking at and the type of decision that is being made. We know that it seems that routine procedures are less likely to be viewed as choices, just something which you go along with, it's what happens. But education and experience increases the chances of seeing there are choices. Not say you want them necessarily, but recognizing them. Anything that involves moral obligations or social obligations are not usually considered to be choices. And one of the concerns with a lot of healthcare decision making is that you may regret the decision you've made later on. And therefore, to take the choice yourself, to be responsible for that choice, can lead to not only regret, but self-blame. In a position where you can't go back and say, oh, well, I'll do it differently now, because it's too late. You've made a decision and the trajectory is moving in that direction. And when you're in that position, you're less likely to see this as a choice. And it's more likely that you will want the professional to advise, perhaps make the decision, and you're more likely to be in a position where you want to trust the professionals to do that. And I suggest that choice does appear to operate where there are desirable alternatives to choose between, but not when they're undesirable alternatives. Okay, I'm going to now show you a simplified form of my research. I hope it's simple. What I'm looking at here is trying to understand where citizens fit in. Simple, generalizable, if you like, to, I call it NHS, but it's any kind of nationalized health service, really, more or less. Seeing government with its health department, whatever its label is, and then the NHS organizational framework, and we can see here, and again, simplification, managers or administrators, professional staff, and ancillary staff. And I'm including ancillary staff because for many patients, they are an important component of the care they receive. The cleaners in the ward, the people who serve meals or whatever. So my interest here is in service users, patients, carers, recognizing that they are part of the social fabric as well. They have family, they have neighbours, they have friends, and there is a linkage there. And there are also some people who take part in voluntary organisations or community groups. And there is a linkage very often with some sort of forum linked in within the health service structure, which patients might directly access, but more often than not is voluntary organisations and community groups. So my interest here is in, and I'm using this in specific ways, co-production between service users and often professionals and ancillary workers, rather than managers directly. Co-management, often between the patient-public forums and managers, and what's called co-governance between voluntary organisations and departments of government, if you like. And Stephen Osborne, for example, has written quite a lot in the business school here on this issue. So public policy on healthcare, I would say, looking at policy around the world, certainly developed countries, is there's quite a large consensus now about patient involvement in definitions of quality, development of it, and the management of it. In Scotland, we have something called patient focus and public involvement, very much around this mutuality agenda. And in England, they call it a similar name, but with a distinct difference, patient and public involvement, which is more about choice. And in fact, they call it the choice agenda. There's also attention around the world on this idea of patient-centeredness, although, as Leslie, my partner, says, in parts of Scotland, it's called person-centeredness. Okay, which means we're not just talking about patients, talking about other people as well. But a lot of the focus on patients is looking at individual patients' experiences of disease, illness, and care, a holistic understanding of personal development issues in family and social contexts, a partnership between patients, practitioners, professionals, and families, that any decisions respect the needs and preferences, whoever makes them, concern with health promotion activity and risk reduction, and finally, patient education and support to make decisions where it is wanted. Well, the research I've done on this with patients and with voluntary groups suggests, in fact, that patients tend to focus, as you might expect, more on service delivery, issues largely around access to services, the quality of those services, and trying to improve relationships with professionals, very much around time and continuity. Voluntary organisations, again, as you might expect, are much more focused on policy and planning. And their concerns are to do with channels for representation, changes in the working practices of statutory bodies, investment in support and training for lay citizens, and their role in developing and implementing involvement strategies. So this takes me into the work I actually started with for my PhD, which is patient satisfaction. And I think I have to be careful and say to you that satisfaction isn't simply saying to people, are you satisfied? rather crude approach trying to understand it. It's more about, so what did you think was going on and what did you feel about it? It's more evaluative judgments than that. But the question here I'm trying to raise is, there's a lot of interest, and certainly since I did my PhD, I'm not saying because of my PhD, but the area has mushroomed from there were probably about half a dozen articles when I was doing my PhD on it, and there are now well over 300,000 worldwide. So it's clearly grown in interest and importance. And I've been able to witness those changes in attention to different aspects of it. But the drivers, key drivers, I think, are about providing public accountability, the legitimacy of government, and quality improvement. Quality improvement, I think, can be at both levels, at micro level, working with professionals, managers to try and make sure the actual service delivery is as good as it can be, making sure the processes are acceptable to those in receipt of them, and reflecting, if you like, the social model of health, not simply a biomedical model. At the macro level, though, there is interest in it because of performance management of the whole system. Are we providing the right services in the right way, spending all this money in a way which we can justify, and using benchmarking to try and make sure that we're learning from outside and between each other. A simplified model, but one which I think a lot of people certainly work on what I call the cognitive aspects. And there is this idea, which I have explored and critiqued, I suppose, is that when people are in receipt of health services, the understanding is that they look at the attributes, so it's a general word for looking at what goes on, which might be physical things, emotional things, but it's mainly about the processes of healthcare. And the theory has it, or some theory has it, that satisfaction comes from a relationship between what people see and what they expect. So they say, I expect very good services, well, it wasn't quite as good as I expected, therefore I'm not going to be very satisfied. Or, I didn't expect very much, and what I got was amazing. I'm really happy. I'm simplifying. I actually looked at this and tested this out, and I've looked at one of the best studies I've ever seen, not mine, showed that actually there was very little relationship. It surprises people, because in marketing this is central to the way they think about satisfaction. Why is this? Well, we're not quite sure, but I think the best we can explain is about 7% of the variation in satisfaction due to expectations. I think one of the issues is that often gets ignored is the emotional side, or the affective component. In other words, a healthcare experience isn't simply an intellectual process. It also involves your emotions, and that can have big impact, because satisfaction itself is an emotional construct. And one of the issues which I was able to pick out of a very broad literature on this, some years ago now, is, and my conclusion was, is because there is an assumed rationality of utility maximizing individuals. In other words, it is assumed that people are making this calculation between this is what I expected, this is what I got, therefore this is what comes out. But in fact, the more I looked at it, the more my conclusion was that expectations may not even exist when people start their healthcare experience. For many people, it's an extraordinary situation to be in. They've never been in that situation before, and hopefully never will be again, and they don't know what to expect, except beyond the bland, ordinary things. They may draw on second-hand accounts, but they may not actually get a very realistic picture of what goes on, and certainly not in their own situation. And it can be very imprecise. And we know that, and I've heard managers say it in the health service, we should manage their expectations to make sure they are satisfied. So it's very open to manipulation. The other thing which concerned me is actually the definition of an expectation. It's used in a simple way, but actually means different things, depends on when it's used. So what I discovered was that people talk about it when what they mean is, this is what we'd really like to happen. It doesn't matter whether it's real or not, this is what we want to happen. It's what I call ideal expectations. Sometimes people say, we've been told this is what will happen, therefore I expect it will happen. It's what I call a normative expectation. But there are other people who say, well, this is actually what I think really will happen. And that's what I call predicted. Now, sometimes these can be the same, but I think you can see that there's a likelihood that they're going to mean different things to different people at different times. And I just reinforce that, and Sarah will love me talking about this. I was involved, I don't know how I got involved, in a project looking at time trade-off. Basically, time trade-off is this idea, you can think of it financially, shall I invest so much money now and in a few years' time get the benefit, or shall I spend it now and I won't have it in the future? Can you do that with your health? Your activities now, your behaviour now might lead to good health for a long time, but maybe a boring life, or you drink and smoke and do everything else now and forget the future until you get there, because you may never get there. Well, we were looking at this in a big study of how people thought about this, and there was, underpinning this is this assumption of utility maximisation. And what I found was, well, I just didn't believe some of the figures coming out. I just found them astounding. Partly because I know from teaching statistics that people's understanding of numbers can be quite variable, and yet they're being asked to give percentages or numbers to these questions. And so we did what was called cognitive interviewing. In other words, we asked people to talk aloud, tell me why you're saying that, or why you reported these figures or these views. Getting people just to think aloud. And we discovered there were a whole series of rationales as to why people gave the answers they did. I'm not going to go into all of them, but I think it was interesting that we came out with at least 7 different alternative rationales to the cost-benefit analysis. In other words, we're complicated people. And so I see a question and I think, for example, well, I could do that, but I've got children. And by the time they're that age, I'll have to change the way I live, and therefore my answer is going to be this. So actually it's not based on how I feel I would, independent of others. It's very dependent on those contexts. Or it might be, I thought it should be a lot. So I came up with this number. Let's call it 1,000. Oh no, that sounds too big. Let's take a naught off, 100. Literally as crude as that. And so it makes you start to question the basis for it, at least with the general public. One of the things I did in my PhD days was to look at what are the things which satisfy and what are the things which dissatisfy people. And I asked it in terms of what are the best aspects of your care in rank order, and what are the aspects that need most improvement. You can't say worst, people won't answer the question. So I derived these, and this was a typical picture in virtually every hospital I went to. It doesn't really matter what the order is, in a sense, but what you can see is, I think, that on the left-hand side, the best aspects, there's something in common, with one exception, and I put the exception in italics. They're all to do with personal relationships, human aspects of care. These are things which satisfy you. Cleanliness is in there. I don't know, cleanliness next to godliness, maybe there's a relationship issue here. On the negative side, again, I think there's something very in common between those items. It's about the physical context of the ward, in this case, except for information. What am I saying? What I'm saying is the things that satisfy are not the opposite of the things which dissatisfy. So that's very fundamental. So, for example, nurses, at least at that time, were top of the tree. They couldn't do anything wrong. They were always number one. However, not always was nursing care that good. But it wouldn't appear on the negative side. It would just go down the hierarchy, the rank order. Here's an example looking at 2 hospitals. This is something which came out of a national organisation called the Health Policy Advisory Unit, which I set up with Maddie Halliday in the audience a long time ago, 1986, I think it was, to run national surveys. And what I'm picking out here is a hospital which had a very high rating in terms of a global rating. What I mean by that, it was a question that basically said, would you be if you had to come back for any reason and you had a choice, would you be very happy to do so, not mind, or rather go somewhere else? And so a high global rating means they don't want to go anywhere else. This was the bee's knees for them. the low-ranked hospital, F in this case, is where they would rather go. I think between a quarter and a fifth would rather go somewhere else, which is very negative for a hospital ranking, or it was at the time. What I've shown you here is when you break it down by the dimensions that people evaluate hospital care on, you will see how it's not a consistent picture. In other words, Hospital C, this wonderful hospital, yes, it was very, very good on physical facilities and food, very good on the physical ward atmosphere, but actually had one of the lowest scores I've seen on medical care and information, and wasn't particularly good on visiting. Hospital F, which you would close down tomorrow if you saw this global rating, had very poor nursing care, relatively speaking, very low scores on physical facilities. It was a crumbling outer London hospital, I can tell you that much. But actually was the paradigm for visiting arrangements. In other words, global measures on their own like this can be very misleading. And that's one of the things I wanted to try and get managers particularly to understand, that it's a bit like league tables. Don't know what's going on here. But right. Is it because I should be moving out? This is the only statistics table I'm going to show, don't worry. But actually, it's a little bit confusing when you start to look at services themselves as a whole. It's a piece of work I did with actually one of my master's students. She did the analysis, and I worked with her on it. And here we have an illustration of some data on NHS Scotland comparing the 4 different types of healthcare. These are odds ratios, which basically means, if you like, in the first one, inpatient care, interpersonal care and information, there's an odds of just over 7. In other words, I should be careful how I explain this, but it means that the higher the quality of interpersonal care and information that you perceived, remember this is bringing together lots of different items, much more likely going to be satisfied with inpatient care. Okay, 7-fold increase for each standard deviation on the dimension. But let's get worried about the details. The illustration there is simply to say that whilst we have to be very careful about global measures, the underpinning message out of this is the importance of the interpersonal care and information. That is where you can make most gains, and that is what will satisfy people the most. But clearly, physical facilities are also important, and waiting and time aspects are important for general practice particularly. So let's now think about how we can look at this. And what I've tried to look at here is the different levels of involvement, from being excluded to having full control, comparing individuals with groups, some related to health, some not, and looking at service delivery, operational policy, and strategic policy. Now, that's a lot of detail, so I'm not going to present all this to you. But let me just say one of the aspects which I want to share with you is this idea of how do people want to be involved in consultations. The consultation might be with a GP, with your hospital professional, therapist. And what we know from the literature is that professionals see it in this way. In other words, they either exclude people, or they might give them information, not necessarily what patients want, but they'll give them information, or they might consult them. That means, what do you think about this? I might ignore it, but at least I've consulted you. Sorry, I'm taking a very cynical view, only because this is where the literature, if you like, is the basis for this. Or it might be the professional makes a decision on behalf, as an agent of the patient, or says to the patient, I'll give you all the information, now you make the decision. But when you ask patients about it, where they have total control, they might say, I don't want to be involved, and there's a whole series of reasons why they may not want to be involved. They might say, I just want information, I want to understand what's going on, or at least be receptive to the information. Others might say, well, I want to do a bit more than that, I want to give my story. And there are some people who want to make decisions entirely on their own, often people with chronic illnesses who've been managing it for years and years and years and feel they know how to manage their healthcare. And what I'm trying to get accepted, well, it's been published for a few years now, is that when we talk about participation, it's very much that co-determined agenda. It's not, this is what patients want, because they may say, I want to give you information, but if the professional isn't listening, there's no dialogue and there's no ability to participate in those circumstances. It's an isolated activity. But it's only through dialogue that you get some participation. And the dialogue itself may lead into shared decision-making if it's wanted. But sometimes patients say, no, we've had the dialogue, we've had the conversation, we understand each other. Now, you please make the decision on my behalf. You know what I want. You know what works for me. But it varies. It varies considerably for the same person in different contexts. It's not a fixed component. So what I've managed to see within this, and this is through qualitative work, which we're still trying to measure more quantitatively, is it will vary according to, it seems to be, the type of illness. Is it acute or chronic? So the more acute the condition, the less likely people want to be involved. The more chronic, greater likelihood. If it's seen, self-perception of very serious, the less likely they want to be involved, and vice versa. Knowledge and experience seems to have a variable relationship. I'm not quite sure how that works yet. More active personalities seem to be more likely to want to be involved, as you might expect. But also, what I find particularly interesting is the issue of professional or trust in professionals. The greater the trust in the professional, the less likely people want to be involved. Where they're not very trusting, they really want to be involved. Okay, I'm just going to move on to interest groups. I will try and speed up a little bit. This is my theoretical framework, conceptual framework. I'm interested here in what are the antecedents to what are the preconditions, if you like, for involvement. What motivation do people have? How do we mobilize people to participate? What level do they want to be involved in? And what mechanisms do they use? Essentially here, and I'm not going to go through all the details, but it's to do with the personal or collective, it's a group, capacity is important. Do they have the capacity to be involved? But also, what are the organizational or institutional opportunities? So one of the things we find that is very important is, for many people, being asked to be involved. So people might say, I'm ready, I've got the ability, I've got the time, but no one ever asked me. Rather than making the demand themselves, they're waiting to be asked, essentially. There's some interesting theoretical research, again, on this. Henrik Bang in Denmark has been doing quite a lot of work on this and suggests, in fact, we have two types of citizen. What he calls the expert citizen, if you like, the usual suspects of the usually derogatory name for them, which I think is unfortunate. They're either grassroots activists who invent these spaces for action, or there are invited spaces where people are brought into it by engagers, political participation engagers. And also this interesting concept of what he calls the everyday maker. Why is it most people are apathetic? Well, I'm not happy with the word apathetic, but I think what he's getting at here is those kind of people, the people who want to do things in their own way, right where they are, when they have time, and when they feel like it. So it's very occasional, and their engagement, as he says, is more on and off and hit and run than that of the expert activist. In terms of motivation, why do people get involved in policy and planning? We're talking mainly about voluntary organisations. It's about utility. That's in there. But it's also the sense of a collective responsibility, the citizenship concern. Also a sense of personal responsibility to do things, and what they feel is a tangible benefit from participation. So those are the kind of motivating factors. What mobilises them, so they might be motivated, but something that mobilises them into action is a feeling of reciprocity, recognition by health authorities, and a sense of equity or inequity, social injustice or justice. This can mobilize people to take action. And just to give you another little bit of numbers, I tested this out in Catalonia in a more quantitative study. And you'll notice here we're looking at people who did not wish to be involved, wish to receive information. This is going back to my original taxonomy. Wish to give information, or wanted to discuss and share decisions. And identified 4 different types of groups. But what is interesting is those who most wanted to do most, if you like, to be at the highest level of involvement were members of voluntary groups. Perhaps that's not surprising, but what interested me was that they were the people who were unrelated to health and healthcare. These are your community activists. Doesn't matter what the activity is, they will be there. They will be having their say and wanting to engage. So let me try and bring this to a conclusion. Some work has been done many years ago, as you can see, by Albert Hirschman, who talked about what do people do with organizations that are failing, or states that are failing. And he identified these 3 components, which I think are quite active components. The first one, which I've mentioned already, exit, the mechanism of the market. Second one, voice, the mechanism of involvement. But he also identified, and I've certainly found this in my empirical work, a loyalty factor. People who believe in the current system. They don't want to exit, they don't want to use voice, they just are loyal. The kind of classic person would be, if you like, the older patient who remembers what it was like before the NHS came into being, thinks this is the best thing ever, and will never say a word against it, but doesn't want to actually be involved in doing anything with it. What I also found was there are a number of passive responses. People might say this is the apathy, but I think it's important to understand what that comprises. One is what I call a fatalistic approach. Well, I can't do anything. I have no power. Or it might be what I called custom, but I've now, the more I read Bourdieu, I think it's to do with what he calls habitus. It's this lack of conscious questioning or desire to change, unless there's something very salient about it. And so I'm coming out with a typology of citizen responses, which I put into these 4 groups: the participants, the compliants, the challenging, and the defiant. But I've yet to do any quantitative work on looking at what proportions and what their characteristics are. So what's the potential impact of involvement? The good aspects would be better decision making. This is what people say, that stakeholder groups will lead to better decisions. It should, if it works well, increase social inclusion and equity and lead to greater democratic governance and accountability. But we need the evidence. On the negative side, it has high resource implications, time, quality of information. It leads to greater exposure of citizens to the uncertainties or lack of evidence, which can undermine their trust. The more they're involved, the more they find out, the more they don't like what they see, because the world is complex. The greater the confusion because of that complexity, the more burden of responsibility for making decisions, which they may not want, increasing potential for competition between different communities over scarce resources, a feeling that the centre ground, the government, if you like, still controls everything, so there's not much room for manoeuvre anyway, even if I do get involved, and for some suspicion over the motives of government. Why are they wanting me to be involved? They never used to want us to be involved, so why are they doing it now? There's an underlying agenda here which I don't understand. So, to finalise, what is the state of the citizenry? And you'll notice I use the word state in a particular way. Well, I think we should look at the social context of citizens. There's an issue around individual cultural capital, as Bourdieu calls it, which is to do with the education, the knowledge, the skills, the attitudes of people, which gives higher status in society. Will people use this to exit? We know they're more likely to recognise choice. Will they take it up? Or will they feel a sense of citizenship in the sense of this is a collective problem. And this takes us into what's called social capital, the networks, the norms, and the trust between us. So I might as an individual have cultural capital, but I can share in the social capital with my fellow members of the community. What about politics and the role of the state? How do we reconcile this problem about democratic legitimacy? Is it through citizen participation? We know they're not voting so much for elected representatives. Are they going to participate? The evidence is not as much as we thought they might. Why not? Are people going to want market regulation or mutual ownership? One of the aspects which I think is interesting to consider is, and it's an argument being put forward, that with increasing economic globalization and competition, then the neoliberals have won the day. And as Fukuyama says, the end of history. It's about neoliberal democratic states. But is it really going to be the end of welfarism? Is it really the same for cultural aspects, society? Economics might be global, but is culture? And I think the argument so far has not shown that that is the case. What we can see, though, is that there's increasing fragmentation politically of governance structures and a lot more regional self-determination. Sitting in Scotland, we can see this going on around us. And my work in Catalonia, it's also happening there. Maybe I'm the cause. But I think at the end of the day, we get the government we deserve. And the question is, how are the citizens going to continue to operate in the future? I don't know, but that's certainly my research agenda, to try and understand how that might play out. Thank you very much.
Andrew, thank you very much. A conversation with the dentist and the GP will never be the same again, will it? Now I really won't know whether I have any choices about anything at all. I'd like to thank Andrew very much for that thought-provoking. It was an insight into something I'd never really thought about. It's quite interesting that so many of the words that you talked about are words we see on TV and newspaper all the time and just accept and never really think about. So as I say, actually a lot of things I think that we look at will actually feel somewhat different in future. I'd like to join me in thanking Andrew for his lecture.
This production is brought to you by the University of Edinburgh.